Ladies and gentlemen, it is my pleasure to welcome you to upcoming webinar organized by the European Rhinologic Society. Following the success of our previous sessions, we are excited to bring you another amazing webinar on pediatric rhinology. Our esteemed speakers will cover some fascinating topics that you don't want to miss and definitely enjoy today. This will include atopic march, allergic rhinitis in children, and evidence-based medicine on adenotonsillectomy and airway surgery. I would like to thank also Olympus, our main sponsor of these sessions. It wouldn't be possible to run webinars without the help of Olympus. And I will moderate it myself. My name is Pavel Serda, and I'm the rhinology consultant at GUISE. Remember, for those who can't make it to the live session, the webinar will be uploaded to the ERS YouTube channel, and it will be available to view at your own pace. And then lastly, at the end will be Q&A session where we can answer your questions. So do not hesitate and type your questions into the chat window. I will be viewing them, collecting them, and then at the end, we can have a look at them together with our experts from field. First talk will be by Olympia Tsilocristou, who is a consultant allergist at GUISE and St. Thomas's Hospital, which is UK largest department of allergy. Olympia has co-authored the European guidelines on allergic immunotherapy for allergic rhinitis, and amongst the other highly esteemed publications. Olympia, I'm eager to hear your talk.
Okay, so I think this should be fine. So first of all, a huge thanks for this kind invitation to participate in this web series from the European Rhinologic Society. It's truly an honor to be able to speak and contribute as an allergist. So as you pointed out, I'll be discussing about the concept of atopic march, and I'll be starting this by referring to the definition. So over the last 2 decades, the term atopic march has been widely used to describe temporal changes in the prevalence of childhood eczema, asthma, and allergic rhinitis. And these are changes that have been reported in epidemiological studies. So what happens is these 3 conditions have evidently a very different peak age of onset. And because of this different peak age of onset, there has been the proposal that there is a sequential progression from one disease to another one, to the other one. And essentially, this is what the term march alludes to. As you can see in the very early stages of the concept of the atopic march, food allergy was not really included, but that's clearly there nowadays based on knowledge that we have established over the years. So you can see that atopic dermatitis is at the very beginning of the process. And essentially, one could say that atopic dermatitis is pretty much acknowledged as an entry point for subsequent allergic disease. And this is because clinically, we have observed for many years that the mean age of onset of atopic dermatitis is much earlier than the mean age of formally diagnosed asthma and allergic rhinitis. And for a lot of scientists, this has been acknowledged probably as a causal relationship, meaning that the onset of eczema is what causes the onset of other allergic comorbidities. However, we have studies from the basic science field that support such a relationship. And I've chosen to present just one here, which is quite significant. And what happened here is that the scientists established a murine model of the atopic march, according to which what they did is they achieved the epicutaneous sensitization to valvulin after tape stripping and developing dermatitis. And what they showed is that this epicutaneous sensitization enabled the later development of allergic inflammation in the lungs. When the mice were challenged, they had a bronchial challenge with the valvulin. compared to the mice that were applied just normal saline on their skin. And this happened, of course, without the need for prior airway sensitization. So what is so much of a problem when it comes to the skin of patients who have atopic dermatitis? And I came up with this figure, which hopefully showcases the differences. And this is how the skin with eczema looks like. So what we can see is that there's a very clearly defective skin barrier, and there is lots of inflammation in the epidermis. While some of the patients who have atopic dermatitis have less filaggrin. This is because of filaggrin mutations. Filaggrin is otherwise a protein that helps the development of the skin barrier. So because of this defective skin barrier, what happens is allergens, which are in direct contact with the skin, can enter the deeper layers of the skin. And because of this, there can be the development of Ig antibodies against the particular allergens, which is acknowledged as sensitization. And the production of Ig antibodies is already an adverse event. It should not be happening. And this is because it may cause the development of allergic disease. But studies have shown that it can also perpetuate the inflammation within the eczematous skin and therefore increase eczema severity. And although, as I said, food allergy was rather like a late entry, if I may say so, within the definition of atopic march. However, currently, in the atopic march concept, where the disease progression is the likely explanation, food allergy and eczema as a link is the more clear one, not only from clinical data, but also from the mechanistic studies. And I've just chose one study to show here, led by Professor Gideon Lack from King's College London, where the team showed that showed the outcome of applying peanut oil on the skin of children that had eczema at the early stages of their life. So what we know very well is that the children that were applied peanut oil had higher chances of being diagnosed with peanut allergy and having a positive peanut challenge compared to the children that were never applied peanut oil on their skin. And going back to the typical triad, if I may say so, like eczema, allergic rhinitis, and asthma, the concept of the disease progression was challenged greatly back in 2014 by this seminal study, which was published by Adnan Kustovic's group. Adnan is based at Imperial College London. So in that article, the team did present cross-sectional changes in the prevalence of eczema, which is depicted with this red line, with an allergic rhinitis, based on data they had from two birth cohorts in the United Kingdom. And this pretty much presents what we have in mind, that most likely eczema comes first, it gets followed up by wheeze, and then by rhinitis. However, in the same article, interestingly, what the authors showed is that when it comes to analyzing individual data, and not just a population level analysis, there are actually 8 distinct clinical phenotypes of eczema, wheeze, and rhinitis. And within these 8 phenotypes, about half of the children did have at least one allergic disease. However, a very small proportion of them had a trajectory that actually resembled the traditional allergic march. Therefore, what the authors suggested is that the relationship between eczema, wheeze, and rhinitis is not really causal. And what they proposed is that eczema, wheeze, and rhinitis are all very common diseases, and therefore they coexist, but mostly as independent entities, each associated to a greater or lesser degree with atopic sensitization. Therefore, what is happening now is that we are moving away from the concept of progression of the disease to the concept of co-expression of the disease. And around this concept of co-expression, I would just like to present some data, acknowledging though that the time is quite limited, so I won't be able to go into depth. But I would just like to draw your attention to the fact that we have some very interesting and actually strong data coming from genetic studies. And I chose to present this study published in Nature Genetics in 2017, where the authors used a comprehensive genome-wide association study to report that eczema, allergic rhinitis, and asthma shared about 99 loci, which means that there's a very strong shared genetic basis for these conditions, which may explain why an individual may have all three of them. And this is something we do know in clinical practice. So for instance, these are data published from the German mass birth cohort, where we can see that when it comes to children from allergic parents, they were the ones who were more likely to have eczema, allergic rhinitis, and asthma at some point during their lives compared to children that came from non-allergic parents. So therefore, the genes do play a role in the development of these conditions. And as far as the microbiome now, I chose to refer to a bacterium, which I know you rhinologists are quite interested in. And this is Staphylococcus aureus, and I'll be just referring to that as staph. So what we know is that staph is implicated in the development of allergic disease, but also in the severity of the allergic disease. And I'll be referencing some data for each one of these diseases. So we know that patients who have eczema are more likely to be colonized with staph on their skin compared to healthy controls. And what we know is that the eczema severity is associated with the levels of the colonization with staph on the lesional skin. And along the same lines, we have some similar data from the allergic rhinitis field. Indeed, what studies suggest is that patients who have allergic rhinitis are more likely to be having staph in their nose compared to healthy controls. And moreover, what seems to be the case is that within the allergic rhinitis population, those who have staph are more likely to suffer with a more severe form of the condition compared to those who don't have staph. And similar data come from the lower respiratory airway disease. So what we know is that skin staph seems to be associated with wheeze and asthma. And these are data coming from longitudinal studies in the US that have to do with children and young adults. And this is a study from Klaus Speichert, which was very nice and showed that the IgE levels against Staphylococcus aureus enterotoxins in the serum of adult patients were actually associated with, significantly associated with the presence of asthma, and especially severe asthma. So again, development of the disease, severity of the disease. And one last aspect coming from food allergy. So this is a study we published back in 2019, where we showcased that children who had eczema and had staph on their skin were the ones who had more increased eczema severity, and they were also the kids who had a difficult time outgrowing their egg allergy or achieving oral tolerance to peanut at the age of 5 and 6. And for these two results, we actually corrected our analysis for eczema severity, and we know that eczema severity was not a factor in this outcome. And moving away from the microbiome, I would just like to point out current knowledge about the role of airborne pollutants in eczema, acknowledging though that the same concept seems to be standing for allergic rhinitis and for asthma. So what we know regarding this environmental impact has to do with the fact that the airborne pollutants seem to be inducing some epigenetic modifications within the utero, which then result in polarizing the immune response towards a Th2 phenotype, which then starts damaging the skin cells and the barrier, okay? It destroys the lipids and related proteins that have to do with the tight junctions, which are these tight associations between the skin cells. And these gaps that get created are the ones that will allow the entry of the pollutants into the skin, and this in turn will amplify the already ongoing inflammation. So in conclusion, what we know now about the atopic march has to do with the fact that it's actually a multifactorial coexistence of disease, okay? And it seems that there are many factors, for instance, the impaired skin barrier, the altered microbiome, for instance, Staphylococcus, the environmental stress, for instance, the pollutants, and various genetic and factors that influence the development of all three diseases. So my take-home message is that yes, there can be patients who will later develop allergic rhinitis and asthma, and these are patients with eczema, and this is the typical atopic march. However, there are multiple atopic trajectories, and there can be patients who never have eczema and they have rhinitis and they develop asthma, and vice versa. Thank you very much for your attention.
Thank you, Olympia. That was a fantastic presentation. And now we can move on to the next speaker. Allow me to introduce Alberto Alvarez-Perea, an esteemed allergist who currently works at the University Hospital in Madrid. With his expertise in his field, Alberto serves as the chair of Food and Allergy Interest Group at the European Academy of Allergy and Clinical Immunology. He is a prolific researcher and has published extensively on the topic of allergic rhinitis in children, among other areas of interest in the field of allergy and clinical immunology. We are privileged to have him here today to speak on this important topic. Alberto, I'm thrilled to hear your talk.
Okay, thank you very much for your very kind presentation, very kind invitation. And I feel, overwhelmed to be speaking to ENTs about rhinitis, but anyway, I'll try to do my best and share with you some ideas and some points. So let's talk about allergic rhinitis in children. Children are an interesting part of the population, right? First, because as we saw in this movie, in Boyhood, a few years ago, children change and change constantly. I mean, we all change, but they do at a pace that is much faster than we do as adults. So chronic diseases such as rhinitis, such as allergic diseases, change with them. So we can just, get to a diagnosis and treat for the treatment, but we have to continue reassessing this patient. It's not the same to have a baby and to have a teenager or an adolescent. I mean, it's pretty clear, right? Another particular characteristic of children is that they get infected all the time. Particularly younger children, they have infection after infection. And especially because we have this custom to send them off to school. And the schools are like giant petri dishes where everything is able to grow and any kind of virus, especially viruses, can skip and can jump from child to child for the whole seasons. Because many of these viruses are seasonal, and this can be particularly hard, or this can make a challenge to differentiate allergic rhinitis, especially seasonal allergic rhinitis, from other seasonal viruses that may mimic the clinics of allergic rhinitis. And finally, in many cases, we can see that children may have some genetic traits and conditions that have not been diagnosed yet because they are young, they have not had the time to be diagnosed. So also this can interfere in the management of diseases. So what's happening with conjunctivitis, with rhinitis, with allergic rhinitis? Well, this is data from Spain, from 2 cross-sectional studies that were led with 10 years difference in 2005 and 2015. And as you can see here, well, they tried to come up with a description of all the patients that were attending pediatric allergy units during a certain period of time. And as you can see, the most common diagnosis, both in 2005 and 2015, for those patients was rhinitis or rhinoconjunctivitis. And not only that, but also in those 10 years, the number of patients that were diagnosed with rhinitis or rhinoconjunctivitis increased by 7%. And this is not a lonely observation. This is data from the ISAC study that was a cohort study led all over the world, trying to establish the incidence of allergic diseases. And as you can see here in the 6 to 7 age group and the 13 to 14 age group, the difference of incidence of allergic rhinitis from the first wave of the cohort study to the third wave, that meant a big amount of years in between, also increased in most of the sites of the study, particularly here is Square Europe. So right now we calculate that the prevalence of allergic rhinitis in children in Europe goes from 20 to 30%. I mean, we are talking about a disease that affects from 1 to 5 to 1 to 3 patients or children in Europe. And why is this happening? Well, there is a wide array of factors to have into account. We have, as we have said before, genetics, but also we have epigenetics, nutrition, exposure to different microbes, family history, and also immunology traits. I mean, the ability to respond in a certain way to something that should be non-problematic, but that these patients are able to respond by IgE. So here you can see how sex can affect the development of allergic rhinitis. While males, this is children at different ages, as you can see here, while in the case of males, of boys, atopy seems to play a very important role for the development of allergic rhinitis. Here in females, in girls, this seems not to be such an important case. I mean, it looks like sex is can be almost as important as atopy itself. So we said before, genetics is very important, and Olympia has explained this to us in the previous talk very nicely. And here we have more data from MAS that Olympia already mentioned, where you can see how having 1 or 2 parents with other allergic diseases increases the chances for the child to have allergic rhinitis, either mild, intermittent allergic rhinitis to persistent and severe. So the pathophysiological pathways that underlie the development of allergic rhinitis are complex. In some cases, are similar to the mechanism that we have seen in atopic dermatitis that Olympia has kindly explained to us. But basically, we could say that in rhinitis, the nasal epithelium plays a very important role. Once it is damaged by different kind of substances, including allergens, the epithelium is able to secrete different cytokines, TSLP, IL-25, IL-33, that can be used to recruit and to activate different immune cells, including ILC2 and T helper 2 T cells that are able to start at T helper 2 response to different allergens. So don't forget that the nose is not isolated from the lung, so it's very common that patients with asthma, up to 75%, have previous allergic rhinitis or concomitant allergic rhinitis, and half of the patients with allergic rhinitis have asthma. So it is important to assess in these patients the possibility, especially in those patients with more severe cases of rhinitis or not respondents, to assess the possibility that they may have also concomitant asthma. So when are we going to think of rhinitis? Well, basically when we have typical symptoms of rhinitis: nasal itch, sneezes, watery discharge. And we are going to think that it might be allergic rhinitis if there is some possible relation with an allergen exposure. And usually there is, as we saw it before, conjunctivitis associated. And what we are going to, we will try to do is to prove the presence of a specific IgE against those supposed allergens by either skin prick testing or testing for serum specific IgE. In theory, this should be very different from infectious rhinitis, but as we said before, infectious rhinitis can also be seasonal, can also have conjunctivitis, and in many occasions in children, especially in younger children, it's going to be hard to distinguish one from the other. And don't forget that in the case of younger children, we may not have still have the diagnosis of some structural diseases that may also mimic allergic rhinitis, septal deviation, adenoidal hypertrophy, colon atresia, or systemic diseases such as primary ciliary dyskinesia or cystic fibrosis. And if we are talking about children, we always have to think that children are children and may behave as such. So let's try to have into account the possibility of other more banal disorders or situations. So basically, for a diagnosis of allergic rhinitis, we will have medical history, we'll have physical examination. Let's remember atopic stigmata, allergic shiners, Denny Morgan lines, allergic crease, and then we are going to try to prove that there is sensitization to those allergens that we suspect that may be behind the rhinitis. In some cases, we may not be able to prove that sensitization if we only try a skin prick test and serum specific IgE. But if we perform a nasal allergen challenge, we might be able to diagnose the patient with local allergic rhinitis, which is a condition where there is no systemic, or at least not detectable systemic IgE, but there is local IgE in the nasal mucosa, and we can see that by performing a nasal allergen challenge. This is a figure from a paper published by our previous speaker, by Olympia Silocristou, where she showed that in children suspected, children with rhinitis, if they perform a nasal challenge, they were able to come up with an additional 8% of patients with allergic rhinitis, in this case with local allergic rhinitis. So let's say traditionally for years now, rhinitis has been divided into two groups, depending on the frequency of the symptoms. We can divide rhinitis into intermittent rhinitis or persistent rhinitis, and depending on the severity of the symptoms, to mild and moderate or severe rhinitis. And depending on the classification of rhinitis, so was proposed to have the treatment set for these patients. So we would have different options depending on severity and persistence of the symptoms. However, in the last few years, we have seen that we might be able to use much easier tools in order to classify patients with allergic rhinitis, such as visual analog scales. Especially with the advent of mHealth and mobile apps that possibilitate that we have easier access to this kind of tools and easier storage and analysis of this information. So this is a screen capture from the application Mask Air, supported by Mac via ARIA, where you can see this very simple slider where the patient only has to say how he is feeling today, or he or she is feeling today. And surprisingly, or at least I see it as surprisingly, VAS has a high correlation with the traditional ARIA proposal for the classification of rhinitis. We are able to see both in intermittent and persistent rhinitis, a high correlation between the VAS and the classification, up to the point that it has been proposed that patients that score over 5 in a VAS should be considered uncontrolled, and patients performing under 2 should be considered well controlled. So in the last revisions of ARIA, these kind of apps can also be used not only for diagnosis and for assessment at one point of the severity of the patient, but also can be used for the follow-up and for reassessment of the patient, and also for correlation of the symptoms with exposure to supposed allergens. So yeah, it comes now. So in the last revisions of ARIA, there have been proposal of using only the VAS, or the score of the VAS, to start the treatment of patients, other patients untreated or that have already had some treatment trials. For the treatment of allergic rhinitis, the important thing to remember is that intranasal corticosteroids are the most useful medications. Actually, most of this data is not well studied in children, but it seems logical that it can be extrapolated from children to adults. And the only combination that would be more potent than the use of intranasal corticosteroids would be the combination of the intranasal corticosteroids with a fixed intranasal antihistamine. And the final part of the talk will cover allergy immunotherapy. I mean, I'm an allergist, I can skip this. There are a big number of trials. You can see here a meta-analysis, including trials of allergen immunotherapy in pediatric children that support the use of allergen immunotherapy to improve the symptoms of allergic rhinitis. When are we going to use this kind of treatment? Well, either when we have a patient that has concomitant asthma, or when we have no asthma, but we have symptoms that do not respond to treatment, or a patient that does not tolerate correctly the treatment, or in some cases when you want to try to prevent the progression from allergic rhinitis to allergic asthma. So if we want to consider treatment our patient with allergen immunotherapy, the first thing we have to do is to be sure that the patient has allergic rhinitis and to be sure that we have a relevant allergen that is causing that rhinitis, and that we have a high quality extract that we can treat the patient with. The second part would be to assess the risk-benefit ratio, and for this, it's very important to have into account the age of the patient, contraindications of immunotherapy, and finally, it is very important to talk to the patient and talk to the family. And this is what I call the car dealer part of the prescription of immunotherapy, because we have to talk about needles, we have to talk about money, we have to talk about schedules, we have to talk about safety, about goals, and we have to be realistic about goals. We can't say to every patient that we are going to cure the rhinitis, and we have to have into account that the patient has a family, and that the family may have also preferences and may also have prior experiences with allergen immunotherapy. And when I said about the schedule, I mean this. In theory, it may seem more interesting for patients to have sublingual immunotherapy compared to subcutaneous immunotherapy, but it may not be the case always. So just to finish, once we have started allergen immunotherapy, this is only the beginning of the treatment, and we have to be always able to reassess and reassess and reassess and reassess any probable outcome of the treatment. So remember that children change, that seasonal does not equal allergy, to have a step-by-step approach to the management of allergic rhinitis, to have the patient choose the treatment, and to have into account that the patient has a family. So that's all. Thank you very much. And I will be glad to address your questions afterwards.
Thank you, Alberto, for a fantastic talk. I think this is very up to date, especially in your case, immunotherapy, very hot topic. So I would be delighted to discuss it at the end in Q&A session. And now let me introduce Mr. Simon Gain, ENT surgeon at the Royal National ENT Hospital in London. With his extensive background in rhinology, Simon is a renowned expert in the olfaction, and he published extensively in this field. He made one of the essentially the first contribution on COVID loss of smell. And today, Simon will be sharing his insights on the evidence on adenotonsillectomy and airway surgery. And we are privileged to have him here.
Thank you very much, Pavel. Thank you very much for inviting me, and thank you very much to everybody for listening to this, and to my very esteemed co-hosts. So I've been asked to talk about evidence-based medicine in pediatric adenotonsillectomy, and unfortunately, EBM can also stand for eminence-based medicine, which is the use of expert opinion and guidelines. And I think part of what makes medicine so challenging and so interesting is that there's art and science. Yes, we have evidence, and I'm going to talk through some of those, but there's also the art of applying that evidence and working where we don't know all of the answers. And that's where guidelines, working groups and things like that come in. So my understanding of where we are in terms of adenotonsillectomy, and I'm not really going to talk about upper airway surgery other than that. I think the evidence for choanal atresia and other things, much rarer diseases, is not really even as good as perhaps the rather embarrassing evidence we have for A's and T's. But the evidence that I'm going to be talking about is just for that for those operations, I think. And when I'm thinking about this operation and the evidence and how we think about it, I really want to think in terms of 5 questions about adenotonsillectomy, and specifically tonsillectomy maybe. Why do I want to do it? How do I want to do it? Who should do it? And where should they do it? And when should they do it? And we can think of these as a way of sort of breaking that down, a little framework for understanding. The why is fairly easy. I think most of us as ENT surgeons in general in our training have come to understand that tonsillectomy is a fairly safe procedure, but not without its risks. And you don't need me to enumerate them, but you're definitely going to give whoever you're doing a tonsillectomy on a very bad sore throat at the very least. So you want to choose your patients carefully for who's going to have the operation. And there's sort of several, two big groups and maybe some smaller groups. The first are the septic or infective causes, so tonsillitis. And it's really important to, oh, by the way, in the corner there is the QR code that has the DOI for the papers that I'm referencing. So not so much if you're here, but if you want to take a screenshot or something, that'll take you straight there. So tonsillitis and the other infective causes, we're talking about serious sore throats here. It's not just an occasional achy throat. These are unwell children, they're pyrexial, they're home from school or college, they are unable to eat, they require antibiotics. This is a significant and debilitating condition. And fortunately for us who look at the guidelines, there's a fairly clear rule that's accepted with the SIGN guidelines here in the UK, in the American Academy guidelines in the States, and the Italian guidelines as well, looking at the number of these procedures. So I remember it as 753-123. So 7 episodes, significant episodes, documented antibiotic use, etc., in 1 year, 5 in 2 years, or 3 a year for 3 years or longer. And the risks of the procedure then balance out versus the risks of these ongoing infective conditions. So 3 a year, that's 3 weeks off work or school. That's pretty significant and life impacting out of 52. So that's severe tonsillitis and recurrent acute tonsillitis. Obviously, if you're going to get horrible complications of your tonsillitis, like a quinsy, that as an abscess needs to be drained, but it's probably going to recur. And usually the indication is once you've had a tonsillectomy, don't give an excuse to come back, take those tonsils out. If, of course, you don't get a quinsy, but your tonsils are bad enough, the guidelines are that if you've been to hospital twice, you've needed intravenous antibiotics, that's usually an indication for tonsillectomy. Now, I have seen people who've bounced in and out of hospital with undertreated Epstein-Barr virus infectious mononucleosis, who've tried to claim that this is 2 hospitalizations. I don't think that's the case. These need to be 2 separate severe hospitalizations. But once you've had 2, you're probably going to get a 3rd, and it's worth having the tonsils taken out. In our guidelines, there is this rather nebulous definition of chronic tonsillitis with sore throats that are affecting the quality of life. I reserve this mainly for tonsilloliths and halitosis with social impact. But there's no doubt that some people just have rather unhealthy looking cryptic tonsils that, while they don't quite meet the criteria, certainly are ruining their lives enough to take it out. So those are the infective causes, and we all are fairly clear that those are sort of high impact intervention for this. But the big change, and you can see this in data I'll present earlier on, is the interventions for sleep disordered breathings. So sleep disordered breathing is going up. We'll look at that in a little bit. Just to say that we still lack guidelines for diagnosis. The current guidelines are that we do not rely on pulse oximetry. There was a study looking at the McGill score for a screening test, which showed that overnight pulse ox had a sensitivity of 47% in whole population, predicting severe obstructive sleep apnea. So doing overnight pulse ox, not useful for deciding who has OSA and who doesn't, and it should be based on clinical decision with the parents involved. Episodes of breath holding at night, etc., which are clinical and history taking. If there is any concern, then full polysomnography can be used. It's expensive. It's rather annoying to do. And even now, the guidelines are still not clear about how exactly we should define that. Is it 1 episode of AHI? Is it 5? We don't know. It's not been agreed, rather. And then finally, the small and sort of add-ons. These are rare conditions that are exacerbated by tonsillitis. So guttate psoriasis can flare with it. You can get nephritis associated with it, and this FAPA syndrome, the periodic fever with aphthous ulcers, pharyngitis, and adenitis, which tonsillectomy is curative for. It's rare, but I have seen it. So now that we know who we're going to be doing the tonsillectomy on, what about what should we be doing? In other words, what technique should we be using? And I think the data is now becoming clearer and clearer that coblation tonsillotomy or tonsillectomy it should be considered as a very strong contender for the best technique. Now, there have been no head-to-head studies that I could find, and a lot of the data is very messy. But if you look at probably the biggest cheerleader for this is Dan Tweedy at Evelina down south of me, down next to Olympia at the Evelina. He's recently published just over 1,200 of his single surgeon cases for intracapsular tonsillectomy using coblation, and really quite amazing compared to our national rates. 0.2% readmission of secondary hemorrhage, none of which went to theatre. I mean, that's just unheard of in over 1,000 cases. It's quite impressive. He also says he's got a 2.6% revision surgery rate, but the majority of those are tonsillar regrowth and reworsening of the obstructive sleep apnea. So a lot of these are for upper airways obstruction. If you look at his follow-ups, their median time to return is 7 days, which we used to say 2 weeks. The readmission rates, if you check their hospital episode statistics, this is a different paper published by my colleague Annika Navaratnam and others looking at the UK-wide data. It's fairly obvious that readmission rates for all causes, which includes pain, are lower with coblation tonsillotomy. A recent Cochrane meta-analysis by Anne Schilder and colleagues looked at this, and they commented that the data was again very confusing, rather heterogeneous, but no strong evidence of tonsillectomy versus tonsillotomy. But it did look, and I believe that by tonsillotomy they mean coblation, although they didn't make it that clear. But they did show that tonsillotomy showed a faster return to normal activity. So again, the evidence is pointing that if you are going to be offering this in the pediatric population, you know who you're going to be doing to it. With the guidelines, this is the technique you should be at least considering. There is some sort of weaker evidence that low wattage bipolar diathermy procedures can mimic this, but that's only in small sample sizes. So if we know who we're going to be doing it on, who should be doing it? Well, it's interesting that there is definitely a learning curve for intercapsular coblation. There's no doubt about this, and this was recognized in the initial UK-wide audit of tonsillectomy, where there was a high rate of postoperative hemorrhage. And even in Dan's case, his first 100 cases, he noticed a 6% revision rate over those times. But once he got out of that 100-case learning curve, it drops to the previously quoted 2.3. So definitely something that you need to take into account if you're going to be offering this. The companies are usually very good at providing training and mentored early treatment. So we know where we're going to do it, we know who's going to do it, and we know who we're going to do it on. Where should we do it? Well, this is quite interesting. This is again looking at the HES data, looking at tonsillectomy for tonsillitis in 0 to 16-year-olds in the UK. This is quarterly, but you can see there's a slight decline in the tonsillectomy for tonsillitis in non-specialist centers, whereas in specialist centers, that's been roughly stable. But if you look at tonsillar hypertrophy, which is probably a proxy for OSA, it's, if anything, been stable in the non-specialist centers, but climbing in the specialist centers. So this seems to indicate that a lot of these patients are being transferred to tertiary and perhaps unnecessarily transferred to tertiary care. In fact, there's the Safe Delivery of Pediatric ENT Surgery Working Group report, which has shown that the data that they have for this is that there's been an 83% increase in tertiary care over that 5-year period, delivery of tonsillectomy. And they feel that this is not correct. Secondary care for the right selected patients is perfectly fine for obstructive as well as for tonsillitis. So the guidelines that they produced are, if anything over 2 years, any UK hospital will be able to deal with, so about 12 kilograms and over, as long as there are no other high risk factors, comorbidities, or extremes of BMI. course, the question is, what is an extreme of BMI? And that's undefined. You could, and certainly what we considered extreme of BMI a decade ago is no longer considered an extreme, but actually normal in the UK. And this is quite concerning, and probably tracking those rates of tonsillectomy. If there is an HDU available in your hospital, then safely 1 year and over can be performed with those same caveats. So when should we do this? And this really is looking at something that I thought was actually well settled, but turns out is not. So how safe is day case tonsillectomy? So this is looking at the GIRF data, again, looking at overnight stay, the black columns versus the gray columns, which are day case surgery. And you can see that this is annualized now, that the overnight stay is really becoming less and less popular. And in fact, there's a recommendation that it should be about 70% is performed at day case. Is that safe? Well, this is looking again, this is real, all the episode statistics collected in the UK. So there are no error bars because this is the actual rate, but a logistic regression looks at the overall difference between the two as not being significant. In other words, day case has no worse readmission rate at 30 days compared to overnight stay. So it's safe in terms of your readmissions. The things that might make your readmission odds increased, well, emergency readmission for hemorrhage and everything else decreased in the secondary care, but increased in tertiary care. And you can imagine that this is because the tertiary care, as we're saying, are seeing the more complex cases and the more tricky kids. Overall, you can see that this tracks what you might expect is that your rate of readmission really drops in the sort of 5 to 7 year olds. Once you started dealing with teenagers, that starts to increase, but it's never significant. And because of this, you can see, and this is real data again, a corresponding rate of daycare surgery. So in the 2 year olds, very, very low, but once you get above 5, it's very common for them to have daycare surgery. As I said, the British Daycare Association suggests that this should all be 70%. So reading this paper and others, I came across an editorial which to me says exactly what I was thinking the whole time. Why are we still debating this? We know daycare is safe. We know it's better for the patients as long as it's done properly, and we should be offering it. So in summary, for those 5 questions that I was talking about, maybe why? Because you're following the guidelines, you're doing it the right thing for the right patient based on the evidence. How? You're going to offer them coagulation preferably, but that you need to have the skill to be able to do that. And if you don't, then the technique that you do have the skill with is appropriate. Where? Secondary care if you can, only tertiary if you absolutely have to. And when? Day case unless you're forced to do something else. So with that, I'd like to thank everybody else who shared their data with me, especially Mr. Navaratnam. And hopefully we have just 6 minutes for questions for all the panelists.
Thank you, Simon, for a very practical presentation, which answered most important questions we all asked. Now, I would like to start with a few questions from the audience. What do you give to your kids that are not old enough for nasal steroids and they've got allergies? So there is a certain threshold for intranasal corticosteroids, but they can't have it because of the thresholds. What would you prefer? I guess we start with Olympia and then Alberto and Simon. Alberto, maybe you can, Olympia, you muted.
Okay, well, we have always that problem with children. There is younger children, there are not that many studies that are that actually let us, in theory, use many of the drugs that we could use. So does that mean that we really cannot do it? Well, I mean, I think that in some cases we can always talk to the family and we can explain them the case, that particular case, especially even though there are no certain indications, there is enough experience. But in this particular case, usually you tend to use in younger children to use intranasal antihistamines that are a bit more potent than oral antihistamines. And in young children, you may use nasal washing and oral antihistamines. That's my opinion.
Olympias, Simon, would you like to add anything to this?
Yeah, I mean, I think in the UK we have the old-fashioned Beckinase, which is licensed down to 2. The newer stuff is only from 6. However, I think if the Beckinase is, for me, if the Beckinase I think is a dirtier drug, it's more systemically absorbed. I would go with the newer drugs, even though they're off license. And pediatricians in general are used to prescribing off license. It's just a natural progression of the way that we fund and do research in drugs. No drug company is going to take the risk of harming kids with the financial burden that might have and the reputational burden that might have for their research. So we're never going to get anything lower than that. But as far as we can see in terms of the models for distribution and metabolism, there's no reason to think that what we know is safer in adults, it would not be safer in kids. So I agree. Talk to the parents, explain the situation, but and if you need to use an intranasal steroid, then use it off license. But with
Olympia, anything to add to this?
Yeah, no, just what I was thinking is that especially when it comes to young children, like preschool age, where typically allergic rhinitis is still not that severe, I think that it would be good if someone considers how frequent, like, viral infections are, and whether using a steroid nasal spray is really needed. I mean, I leave it to you two ENT doctors, but that I would just like to bring this to the table.
Yeah, I would like to ask the question myself. Alberto, is there? Can we say now that immunotherapy, especially for the dust allergy, can prevent further atopic march?
Well, first of all, disclaimer: I don't really believe in the atopic march. So yeah. I mean, I really agree with the final slides of Olympia's talk. I think that there is a lot of overlapping. There are many mechanisms that are common. So they are more concomitant diseases or different expressions of one disease underlying all of them. But can we prevent with the atopic march or with immunotherapy? I'm not sure we can say that. It makes sense. It may have some rationality behind it, but I'm not sure we can say that for sure. Yeah. I don't know, Olympia, what do you think?
Yeah, I think there are some studies that have showed less prevalence of asthma when it comes to patients who received immunotherapy for their allergic rhinitis. But I agree, probably it's not enough to make robust recommendations. Although I must admit, it's something we do mention to the patient when suggesting allergen immunotherapy, that potentially this can help the progression of allergic rhinitis into asthma. So in practice, we do mention that to the patient. Yeah, for sure. As an allergist, at least I do. Alberto, I presume it's something. I mean, it may not be like a definitive argument, but it's something we do mention.
I don't think there is now a recommendation or studies that will show significant change, but I think there is only trends at the moment. I think we need to look into the future. Simon, how do you feel about this?
I mean, I as somebody who's had sublingual immunotherapy and had his asthma cured by it, And remarkably, in which I did not expect at all. I wonder whether the fact that you get better from your lower rates of asthma is due to the allergic march, or whether it is just the same, you're influencing the same mechanisms. I just wanted to go back to your very good point about recurrent viral infections mimicking allergic rhinitis. You're absolutely right. We should consider that. I saw some data a while ago looking at Azaflu as dimester, and you mentioned the disruption of gap junctions in your talk and it looked like the therapy with, and it was combination, so we don't really use that unless they're very severe in the kids, but it looked like therapy with steroid and antihistamine tightened the gap junctions, and it increased epithelial integrity. So you may want to be doing that anyway in a viral infection. I don't know. I mean, that's very, very
good point.
hypothetical.
Now, having said that, is there any increase in the incidence of allergic related diseases with the extensive use of the hand sanitizers during the COVID? I think there is some data on that, but I'm not the expert. Nope.
I'm not aware of this.
No, I'm not aware of that.
No?
There is that Danish big cohort on that, but obviously we don't have enough time to be able to say anything much about that, but I guess it makes sense. There is another question from the audience. Child with rhinitis, which is unresponsive to medical treatment and underwent adenodectomy, no improvement. What turbinoplasty techniques are appropriate for child 5 to 15 years old? Simon, I guess this is mainly on you.
I think you're making a very large jump there. There's a very big gap in the middle of that question, which I would like to stick my fingers in a bit. So what you're saying is that the patient has symptoms of rhinitis.
Yeah, that's from the audience. So I understand.
Sorry, the person asking the question. So when your treatment doesn't work, you go back to the beginning and you start all over again, and you think, what have I missed? What diagnosis have I not made? So personally, I would look and see what supports the diagnosis of rhinitis, non-allergic or allergic. Presumably they had an adenoidal obstruction, which is provable on nasendoscopy or even lateral x-ray if that's your way. So you'd expect that to get better. I would not go straight for turbinoplasty. Turbinates, we now are realizing more and more. In fact, there was a Nature Communications paper looking at the vasculature of the nose just this week. These are dynamic structures within the nose. I think you mess with them at your peril. So I personally would go back, and I don't see many pediatric patients anymore, but I would go back and I'd start again, and I'd drag a colleague in, an allergist or somebody else to just give them, or an immunologist, give them once over. Alberto mentioned that the whole series of possible causes of mimics of pediatric allergic rhinitis. And that's a very sort of comprehensive checklist to go through. So local allergic rhinitis is obviously the big one that Olympia mentioned. Olympia published, Alberto mentioned. And I think you need to start from the beginning before going for a juvenile turbinoplasty. I really would. I don't know what you think, Pavel.
I'm exactly on the same page. So I think the reasons for the turbinoplasty indications are less and less. And I would say that it's very limited procedure, especially in the allergic rhinitis, and we almost don't see it that much now, and I think very rightly. So some limited cases where you might have like an extensive osteitis within an inferior turbinate. Theoretically, it's nice, but in the real world, it doesn't really happen much.
Yeah. So not in kids, but if there's swelling that doesn't seem to improve with systemic steroids, things like that, where you just cannot make any difference in that, I would have to be pushed to do a turbinoplasty, and even then it's very limited. And coblation for me, I think, is quite helpful. Radiofrequency.
Same here. And I would guess the last question, because of the time, if the indication for tonsillectomy is due to recurrent tonsillitis, do you still prefer intracapsular tonsillectomy by coblation?
Yeah, that's a good question. I think the data is that it does seem to work for intracapsular tonsillectomy, and I just think that I didn't present that that the upside is so great in terms of these kids are straight back on their feet. I mean, I've had patients go back to school within a couple of days. I know this is anecdata, not fully, but there are concerns about remnant tonsillar tissue. And that's not nothing, and there is a recurrent tonsillitis rate, but it is very, very low when you it's almost debulk. It's not really. I mean, you can do a very good full tonsillotomy, but I think the advantages are so great. Even if your results aren't as good as Dan Tweedy's, which, let's face it, no one's will be, in my hands, I would still go for that first, and I even do it in adults actually.
Thank you. I would like to close the webinar this way because of the time. I thank the speakers for great talks, and I would like to thank again Olympus for sponsoring webinar series, and we're looking forward to see you next week for the next webinar. Have a nice.
Thanks, everyone.
Thank you very much.